Namaste everyone, welcome. So today we are going to discuss a really fascinating organ, the uterus. Now look, this is not just any other muscle in the body. No, it is completely unique. And why is that? Because from a pharmacology point of view, from our point of view, we need to have two totally opposite kinds of control over it. We have to know how to make it contract with incredible force. And at the same time, we need to know how to make it completely relax. It's a proper tug-of-war. Chalo, let's get into it.
So this brings us to the big question for today. Just think about it for a second. We have one muscle that has to do two completely opposite jobs. It has to push with immense power for delivery, but it also has to pause and stay totally quiet for 9 months. So the question is, how do we doctors actually take control of this situation? How do we know when to press the accelerator and when to slam on the brakes? Let's find out.
Okay, so first things first, let's talk about the accelerator. Let's talk about the go signal. These are the drugs that stimulate the uterus that make it contract, and in pharmacology, our term for them is simple: uterine stimulants.
So what are they exactly? It's quite simple, actually. These are drugs that do three main things. They increase the force of the contractions, they increase the frequency, that means how often the contractions happen, and they increase the duration, which is how long each one lasts. And the classic example, the one you absolutely must remember for your exams, is ergometrine. It's from the family of ergot alkaloids.
And you can see that three-step action right here. It's a very simple but incredibly powerful mechanism. Ergometrine makes contractions stronger, more frequent, and longer lasting. You put all three of those actions together, and what you get is a very powerful, sustained contraction of the entire uterus.
But why? Why do we need such a powerful contraction? What is the critical mission here? It is all about controlling and preventing something we call postpartum hemorrhage, or PPH. You see, after delivery, a tightly contracted uterus will literally squeeze all the blood vessels shut and stop the bleeding. This one action is absolutely 100% life-saving.
Now, of course, in medicine, we are always trying to improve. So ergometrine has a more modern successor called methyl ergometrine. Now, this one is 1.5 times more potent on the uterus, but here's the real key improvement. Its other effects on the rest of the body, like on blood vessels, are much less. This makes it a much more targeted, a more specific drug, and that's why it's often the one we prefer to use in our obstetrician units today.
All right, so we've covered the accelerator. Now let's completely switch gears and talk about the brakes. We need to look at the drugs that do the exact opposite. This is our stop signal, what we call uterine relaxants, or the more technical term is tocolytics.
And when it comes to hitting the brakes, well, it's not just one pedal. We have a whole toolkit at our disposal. There are 4 main classes of these relaxant drugs. We have adrenaline agonists, calcium channel blockers, oxytocin antagonists, and a few miscellaneous drugs. This gives us many options depending on the patient's exact situation.
And what is their job? Well, the definition is as straightforward as it gets. Tocolytics are simply drugs that decrease uterine motility. That's it. In other words, they just tell the uterus, hey, calm down, relax, stop contracting. They are, quite simply, the brakes.
Now, you might be thinking, why on earth would we ever want to stop uterine contractions? And the main reason, the critical mission here, is to delay premature labor. You see, if things start happening too early, we can use these drugs to hit the pause button. This can buy us precious days, sometimes even weeks. And that extra time inside is everything. It allows the fetus to mature, and crucially, for its lungs to develop. This can make all the difference for the baby's survival.
Okay, so now that we've seen the whole toolkit, let's open it up and take a closer look at a couple of these tools to understand exactly how they work. We'll focus on 2 of the most commonly used categories.
First up, we have adrenergic agonists. A key example here is ridodrine. It's a beta-2 selective agonist, and its goal is to suppress that premature labor. But, and this is a very important but, it's not without its problems. It can cause some significant side effects for the mother, things like a racing heart or changes in her blood sugar levels. So we have to be careful.
Now, for a totally different approach, calcium channel blockers. How do they work? Okay, remember this one basic biological fact. For any muscle to contract, it needs calcium to get into the cells. Calcium is like the key that starts the engine. So what these drugs do is brilliantly simple. They just block the channels that let the calcium in. No calcium, no contraction. The muscle relaxes. It's that simple.
A very common example here is a drug called nifedine. Now, its effectiveness is just as good as the beta-2 agonist we just talked about, but it has one major advantage. Generally, it causes fewer side effects.
And that makes it a very, very attractive option for us doctors. Of course, it's not completely risk-free. It can still cause some issues, but the profile is much better.
Which brings us to a very, very important point. Whether we are pressing go or stop, these are powerful drugs. This is a very delicate balancing act, and a good doctor must handle these with extreme care. And a big part of that is knowing exactly when not to use them.
So let's start with the stimulants, the go drugs. You would, of course, avoid a drug like ergometrine if the patient has vascular disease or high blood pressure, right? Because the drug itself can raise blood pressure even more. It's also contraindicated in very serious conditions like toxemia of pregnancy, sepsis, or if the patient has significant liver and kidney disease. Common sense must prevail.
And similarly, with the relaxants, there are times we must not intervene. We do not try to stop labor if, for example, the membranes have already ruptured, or if there's bleeding, or a serious infection inside the uterus. In these situations, trying to delay labor could cause much more harm than good. The body is telling us it's time, and we have to listen.
Okay, so let's bring this all together. What is my final takeaway for you? We have seen two completely opposite forces. We have the stimulants that tell the uterus to push, and the relaxants that tell it to pause. Ultimately, pharmacology of the uterus is all about applying the right force at exactly the right time.
You know, this quote really sums it up perfectly. What we are doing in obstetrics with these drugs, it's not just a science. It's really an art form. It is the art of knowing exactly when to say go to make sure delivery is safe and to prevent bleeding, and knowing precisely when to say stop to give a premature baby the best possible chance at life.
And I will leave you with this final thought to take with you. This constant tug of war, this pharmacological balancing act between starting and stopping such a fundamental process, what does this teach us about the incredible level of precision, the judgment, that is required not just here, but in every single field of modern medicine? Something for you all to think about. Thank you.